بلادي يا سنة الفجر
وينبوع الشذا العذري.
Welcome to this session on the principles of assessing a critically ill patient in the intensive care unit. Assessment in critical care is never a single event. It is a continuous, structured, and adaptive process that begins the moment the patient arrives and continues throughout their entire stay. The purpose of the initial assessment is simple yet vital: to identify immediate threats to life and to stabilize the patient using a systematic emergency approach. This involves evaluating the airway, breathing, circulation, neurological status, and exposure. Once the patient is stabilized, our focus shifts to a more deliberate and detailed assessment. We explore the underlying illness, the patient's physiological reserve, their past medical history, and their response to treatment. High-quality intensive care assessment requires a combination of clinical skill, careful observation, interpretation of investigations, and effective teamwork. Communication is essential, and clear documentation ensures continuity of care, supports clinical decisions, and helps track the patient's progress accurately. Whether we are conducting a rapid emergency review or a structured daily examination, our priorities remain the same: recognize deterioration early, prevent complications, and guide the patient safely through their critical illness. Let us now look at the difference between the initial assessment and the subsequent assessment in the intensive care unit. When a critically ill patient first arrives, our priority is to identify any immediate threats to life. At this stage, we do not aim for perfection. We aim for safety, speed, and stabilization. The initial assessment follows an emergency structure, beginning with airway evaluation, followed by breathing, circulation, disability, and exposure. This process allows us to detect life-threatening problems quickly and to begin immediate interventions such as airway management, oxygen therapy, hemodynamic support, or urgent imaging. Once the patient is stabilized, our approach changes. We transition from emergency actions to a more detailed and thoughtful examination. This subsequent assessment is systematic and comprehensive. It includes a focused and detailed history, a complete head-to-toe examination, and planned investigations that help us refine the diagnosis. During this phase, we explore the underlying cause of the illness, the patient's physiological reserve, and their expected response to treatment. The initial assessment asks, what will kill this patient in minutes? The subsequent assessment asks, what is the full clinical picture, and how do we guide this patient safely through their recovery? Recognizing the difference between these two phases is essential for effective and safe intensive care practice. History taking remains one of the most valuable components of assessing a critically ill patient, even in a highly monitored intensive care environment. It is essential to remember that monitors, charts, and laboratory values are only part of the story. The patient, whenever possible, should remain our primary source of information. Many critically ill patients may be conscious only briefly before their condition deteriorates, which means that obtaining a timely history can be crucial. During the initial phase, we obtain a focused history that helps identify the reason for deterioration, the timing of symptoms, relevant past illnesses, and any immediate hazards such as allergies or medications. Once the patient is stabilized, we explore a more detailed history, including past medical conditions, surgical history, previous admissions, daily medications, and the presence of any chronic illnesses that may influence prognosis or response to treatment. We must also understand the patient's physiological reserve their quality of life prior to admission, and their personal views regarding aggressive interventions. In many cases, family members, caregivers, or referral documents become essential sources of information, especially when the patient is unable to communicate. Good history taking not only guides diagnosis and treatment, but also ensures that our interventions align with the patient's values and long-term goals. Ultimately, even in a technological environment such as the intensive care unit, history remains central to safe and effective patient care. Physical examination in the intensive care unit must be systematic, structured, and repeated regularly. We begin by confirming the basic measurements: the patient's height, weight, and predicted body weight, as these values influence ventilation settings, drug dosing, and nutritional planning. We then move to the central nervous system assessment, evaluating the pupils for size and reactivity. Assessing the Glasgow Coma Scale or the full outline of unresponsive score when appropriate. Looking for signs of delirium, monitoring sedation levels using the Richmond Agitation Sedation Scale. And assessing pain using validated tools such as the Numeric Rating Scale or the Critical Care Pain Observation Tool. In patients with neurological risk, pronator drift, motor power, sensation, and seizure activity must be monitored frequently, while intracranial pressure and cerebral perfusion pressure are reviewed continuously when monitoring devices are in place. Next, we assess the respiratory system, starting with airway status, the position and size of the endotracheal tube, and cuff pressure. We observe the pattern of breathing, look for the use of accessory muscles, and auscultate the chest for equal air entry and added sounds. For ventilated patients, we review the mode, tidal volume, plateau pressure, driving pressure, and minute ventilation, as well as oxygenation indices such as the ratio between arterial oxygen and inspired oxygen concentration. In non-intubated patients, we assess cough strength, secretion load, and swallow function. The cardiovascular examination includes a review of the heart rate, rhythm, blood pressure, and mean arterial pressure, as well as an assessment of peripheral perfusion through capillary refill, extremity temperature, and pulse quality. We look for signs of fluid overload or edema, evaluate mucosal hydration, listen to the heart sounds, and review any hemodynamic monitoring values, including central venous pressure, cardiac output, systemic vascular resistance, pulmonary pressures, and pulse pressure variation when available. The abdominal assessment involves evaluating bowel sounds, abdominal distension, tenderness, and surgical drains. We measure abdominal girth when indicated and monitor intra-abdominal pressure in patients at risk of abdominal compartment syndrome. Nutritional status is reviewed daily, including calorie and protein targets, feeding route, tolerance, and residual volumes. The examination of the skin and extremities includes checking for pressure areas, wounds, bruising, or rashes, and assessing for signs of deep vein thrombosis. The Braden score is used daily to evaluate the risk of pressure injury. Finally, we inspect all lines, catheters, drains, and tubes, confirming insertion sites, dates, dressing integrity, and function, because these devices pose both life-saving benefits and infection risks. This comprehensive head-to-toe approach ensures that subtle changes are recognized early, complications are prevented, and the patient's progress is guided safely and effectively. Don't worry, we will go through each system examination in this course. This is only a general overview to help you understand where everything fits into the wider intensive care assessment. Social and ethical considerations form an essential part of evaluating a critically ill patient, because clinical decisions must always align with the patient's values, preferences, and overall goals of care. We begin by identifying the surrogate decision maker, the person legally or practically responsible for making choices on behalf of the patient when they are unable to do so themselves. It is important to clarify the relationship, communication structures, and the family's understanding of the patient's current medical condition, as misunderstandings at this stage can complicate care. Goals of care should be discussed early, exploring whether the patient previously expressed wishes about treatments such as resuscitation, advanced life support, mechanical ventilation, or major interventions, and documenting any advanced directives or do not attempt resuscitation decisions that may apply. These discussions are not only about limiting treatment, they also help guide the intensity of care, prioritize comfort, and respect the patient's dignity during severe illness. Frailty assessment is another key component, as frailty strongly influences prognosis, recovery potential, and the likelihood of long-term dependence after a critical illness. By evaluating a patient's baseline mobility, functional independence, cognitive state, and overall resilience, we gain insight into what recovery might reasonably look like and can tailor our treatment plans accordingly. Social issues such as the patient's living situation, family support, financial challenges, and caregiving responsibilities should also be considered, because these factors directly affect discharge planning, rehabilitation, and the feasibility of ongoing treatments. Together, these social, ethical, and personal dimensions ensure that intensive care is not just physiologically correct, but also morally responsible, culturally sensitive, and aligned with the individual patient's life story and personal values. Severity scoring systems are an essential part of modern intensive care practice because they provide an objective framework for evaluating how ill a patient is, predicting outcomes, and guiding clinical decision-making. These scores are not used to replace clinical judgment, but to complement it by offering structured, reproducible assessments that help us communicate clearly, allocate resources appropriately, and audit the quality of care. The Sequential Organ Failure Assessment, or SOFA score, evaluates the degree of dysfunction across major organ systems and is particularly useful for identifying organ failure trends and recognizing deterioration early. The Acute Physiology and Chronic Health Evaluation, too, better known as APACHE 2, combines physiological data with chronic health indicators to estimate mortality risk and is often used for benchmarking and research comparisons between ICUs. In resource-limited settings, the Tropical Intensive Care Score, TROPICS, offers a more accessible tool by focusing on simple bedside variables and basic investigations, helping clinicians assess severity even when advanced diagnostics are not available. Condition-specific scores, such as the Intracerebral Hemorrhage Score, guide prognosis and treatment discussions in neurological emergencies. While each scoring system has strengths and limitations, using them consistently ensures that trends are recognized early, treatment plans can be escalated or de-escalated appropriately, and families can be counseled with greater clarity regarding expected trajectories. Importantly, these scores help the multidisciplinary team discuss the patient's condition using a common language, reducing ambiguity and improving continuity of care. Also, we will go over ICU scoring systems one by one later in this course, but before that, it is important to understand how investigations and imaging integrate into the daily assessment of a critically ill patient. Investigations in the intensive care unit must be purposeful, timely, and interpreted in the clinical context, because critically ill patients can deteriorate quickly and laboratory trends are often more meaningful than single values. We begin by reviewing routine daily blood tests, including full blood count, renal profile, liver function, electrolytes, coagulation markers, and arterial blood gases, analyzing not only absolute values but also whether these results reflect stabilization, improvement, or worsening organ function. Point-of-care ultrasonography is now a fundamental bedside tool in critical care, helping to rapidly assess cardiac function, intravascular volume status, pulmonary pathology, and abdominal complications without delaying treatment. Chest radiographs are reviewed for tube positions, lung expansion, infiltrates, pneumothorax, effusions, and postoperative changes, while computed tomography may be required for more complex neurological, thoracic, or abdominal diagnosis. Microbiological investigations are followed closely, including pending cultures, sensitivity patterns, and polymerase chain reaction tests, as these results guide antimicrobial therapy, infection control strategies, and decisions regarding de-escalation. Any missed, delayed, or abnormal investigation must be addressed promptly to prevent deterioration or delays in treatment. We also assess the relevance of each investigation, whether it was necessary, whether it should be repeated, and whether the result has influenced management, because unnecessary testing can increase cost, cause harm, or lead to false reassurance. Finally, integrating all laboratory and imaging findings with clinical examination creates a coherent picture of the patient's condition, supporting better decision-making, safer care, and more accurate anticipation of complications. Medication review is a fundamental part of the daily assessment in the intensive care unit because critically ill patients are highly vulnerable to drug errors, adverse reactions, and unpredictable pharmacokinetics. We begin by reviewing every prescribed medication, confirming the indication, the dose, the frequency, and the route of administration, ensuring that each drug is still clinically necessary and appropriately tailored to the patient's current physiological state. Particular attention is paid to drugs that require renal or hepatic dose adjustments, as organ dysfunction can make standard doses harmful or ineffective. We also assess whether any medication may be contributing to hypotension, delirium, respiratory depression, or metabolic derangements, because these complications can mimic disease progression and delay recovery. The route of administration is reviewed carefully, especially in patients with impaired absorption, malabsorption, or gastrointestinal dysfunction, where intravenous delivery may be more reliable than enteral routes. High-risk medications such as vasopressors, sedatives, anticoagulants, insulin infusions, and anticonvulsants are checked meticulously for correct dosing and infusion rates, as even small deviations can be dangerous. Drug interactions are assessed using both clinical judgment and available interaction tools, particularly when combining antibiotics, antifungals, opioids, sedatives, or cardiovascular medications, as these can alter metabolism, prolong QT intervals, or increase toxicity. We then confirm that all infusions are correctly labeled, that lines are not unnecessarily duplicated, and that drug compatibilities are respected to prevent precipitation, inactivation, or accidental boluses. Medication timing is also reviewed to ensure appropriate therapeutic windows, especially for antibiotics, where delayed or inconsistent dosing can worsen outcomes and promote resistance. Finally, we verify that all medications stopped, changed, or initiated in the last 24 hours are clearly documented and communicated to the entire multidisciplinary team, ensuring continuity, safety, and a shared understanding of the therapeutic plan. Reassessment is one of the most important elements of intensive care practice because no treatment is complete until we have confirmed its effectiveness, safety, and impact on the patient's overall condition. In the ICU, we reassess continuously, observing whether interventions such as fluid administration, vasopressors, ventilation adjustments, analgesia, antibiotics, or procedures have led to measurable improvement. We begin by evaluating vital signs, looking for stabilization or deterioration in heart rate, blood pressure, respiratory rate, temperature, and oxygen saturation, as these immediate parameters often provide the earliest indication of treatment response. Organ function is reviewed next, monitoring changes in urine output, mental status, oxygenation indices, lactate levels, acid-base balance, and laboratory markers of renal, hepatic, or hematological function. These trends help determine whether the patient is moving towards stability or whether further intervention is required. We also reassess clinical symptoms such as breathlessness, pain, abdominal distension, secretions, and neurological signs, because these often change before numerical values do. If the patient is ventilated, we evaluate the impact of any modifications to tidal volume, positive and expiratory pressure, driving pressure, or inspired oxygen fraction, and whether these changes have improved gas exchange or reduced ventilatory stress. Likewise, we review the effects of vasopressors or inotropes, analyzing whether perfusion has improved, lactate is falling, and organ function is stabilizing. Reassessment also involves identifying complications or unintended consequences of therapy, such as fluid overload, arrhythmias, hypoglycemia, renal injury, or sedation-related problems. Importantly, the findings from each reassessment must be documented clearly and communicated to the entire team to guide subsequent decisions and ensure continuity of care. Ultimately, reassessment is not a single step but a continuous cycle. Observe, interpret, respond, and reassess again, allowing us to refine treatment, anticipate deterioration, and support the patient's progress towards recovery. The assessment of a critically ill patient in the intensive care unit is not a collection of isolated steps, but a unified, structured workflow that guides safe and effective care from the moment the patient arrives until the point of recovery. We begin with an immediate rapid assessment using the airway, breathing, circulation, disability, and exposure framework, ensuring that life-threatening problems are identified and treated without delay. Once the patient is stabilized, the focus shifts to a more deliberate and comprehensive head-to-toe examination, supported by targeted investigations, imaging, and continuous monitoring. History is gathered early and refined throughout the admission, helping us understand the patient's physiological reserve, pre-existing conditions, functional status, and goals of care. We then proceed through systematic assessment of each organ system: neurological, respiratory, cardiovascular, gastrointestinal, renal, metabolic, skin, and extremities, documenting findings, trends, and clinical priorities. Alongside this, we evaluate all lines, catheters, and invasive devices, ensuring they remain necessary and safe. Infectious disease surveillance continues in parallel, with careful review of cultures, biomarkers, isolation needs, and antimicrobial stewardship. Daily safety checks ensure that fundamental care elements, feeding, analgesia, sedation, thromboprophylaxis, positioning, glycemic control, bowel care, mobilization, and device review, are never overlooked. Medication assessment remains a cornerstone of this workflow, verifying correct dosing, interactions, infusion rates, and therapeutic intent. Throughout the process, severity scores such as SOFA, Apache-C, Tropics, and condition-specific tools help quantify illness, recognize trends, and support prognostic discussions. Continuous reassessment links every part of the workflow, allowing us to measure the patient's response to treatment, identify complications early, and adjust our management accordingly. Bringing all these elements together creates a coherent, dynamic, and patient-centered approach to critical care assessment, ensuring that treatment is not only scientifically sound, but also safe, consistent, and responsive to change. Thank you for your attention throughout this session and for your commitment to improving the care of critically ill patients. Assessing a patient in the intensive care unit requires structure, vigilance, teamwork, and compassion. And every element we covered today forms the foundation of safe and effective critical care practice. I hope this session has given you a clear understanding of the full assessment workflow and prepared you for the deeper, system-by-system teaching that follows in the coming modules. Your dedication to learning directly translates into better outcomes for the patients who depend on us during their most vulnerable moments. Thank you once again, and I look forward to continuing our journey together in the next session. Thank you for watching. If you found this lecture helpful, please don't forget to hit like, share it with your friends, and subscribe to our channel for more educational content. And if you'd like to explore more lectures, clinical notes, and recorded courses, you can always pay us a visit at our website at AnesthesiaSD. Once again, thank you for your time and support. Then I look forward to seeing you in the next session.